Dear students, Assalamu alaikum. In the last lecture, we studied the clot retraction, the formation of plasmin by various plasminogen activators, and the intravascular anticoagulants. In today's lecture, we will continue with the clinical anticoagulants and disorders of hemostasis. Apart from intravascular anticoagulants which operate within the blood vessels, anticoagulants can be administered clinically in patients at risk of excessive blood clotting. These anticoagulants either inhibit the action of coagulation factors or interfere with their synthesis. Heparin is a very common clinical anticoagulant. It is used widely as a pharmacological agent. Commercially, heparin is extracted from different animal tissues. Heparin is given in the dose of 0.5 to 1 milligram per kilogram of body weight intravenously. This can cause the blood clotting time to increase to 30 or more minutes, and this change in clotting time is instant. The action of heparin lasts about 1.5 to 4 hours. Next, a group of clinical anticoagulants are the Coumarins. When a Coumarin such as warfarin is given to a patient, the amounts of active prothrombin and factors 7, 9 and 10 begin to fall. Warfarin inhibits the enzyme vitamin K epoxide reductase complex 1. The coagulation factors are biologically inactive and they have greatly decreased coagulant activity. After administration of an effective dose of warfarin, the coagulant activity of the blood can decrease to about 20% of normal by the end of 24 hours. Normal coagulation usually returns 1 to 3 days after discontinuing Coumarin therapy. Anticoagulation outside body means to keep the blood in the fluid state for various tests or for blood transfusion. The different methods employed for this purpose include the use of, number 1, the siliconized containers. Blood collected in these containers does not clot for about 1 hour. The reason is that the silicone coated surfaces prevent contact activation of platelets and factor 12. Number 2, heparin can be used for preventing coagulation of blood outside the body. It is used in surgical procedures involving heart-lung machine or artificial kidney machine. Number 3, oxalate compound cause the precipitation of calcium and thereby decrease the ionic calcium level so much that blood coagulation is blocked. Number 4, negatively charged citrate ion in the form of sodium, ammonium or potassium citrate combines with calcium in the blood to cause an unionized calcium compound, thus preventing coagulation. Now, after learning the mechanisms underlying blood coagulation and anticoagulation, we shall now study the disorders of hemostasis. Disorders of hemostasis can be divided into two major groups: conditions that cause excessive bleeding and the thromboembolic conditions. We will first study the conditions that cause excessive bleeding. Conditions causing excessive bleeding include decreased clotting factors, hemophilia, thrombocytopenia, that is platelet deficiency. Let's first study the conditions that involve decreased clotting factors. In one of the previous lectures, we learned that almost all of the blood clotting factors are formed by the liver. Therefore, diseases of the liver such as hepatitis and cirrhosis can depress the clotting system, leading to bleeding. The role of vitamin K in clotting is also important. Vitamin K is an essential factor to a liver carboxylase enzyme that adds a carboxyl group to 5 important clotting factors, namely prothrombin, factor 7, factor 9, factor 10, and protein C. As a result of this reaction, vitamin K itself is oxidized and becomes inactive. Vitamin K deficiency seldom occurs in healthy persons, as vitamin K is continually synthesized by intestinal bacteria. However, as vitamin K is fat soluble and is absorbed into the blood along with the fats, its deficiency can occur in gastrointestinal diseases, in which there is poor absorption of fats. Another very prevalent cause of vitamin K deficiency is failure of the liver to secrete bile into the gastrointestinal tract due to liver disease. Now, this lack of bile prevents adequate fat digestion and absorption, and therefore depresses vitamin K absorption as well. Vitamin K is injected into surgical patients with liver disease or with obstructed bile ducts before the surgical procedure is performed. The next disorder of hemostasis is hemophilia. There are 3 types of hemophilia: A, B, and C. The clinical manifestations in hemophilia include basically the hemorrhage, which means bleeding, and this can occur after trauma and operation Even a simple procedure like tooth extraction can lead to prolonged bleeding. The bleeding can occur into mucous membranes, or into tissues, or into joint cavities. Hemophilia A. It is caused by deficiency of smaller component of factor VIII. Loss of the large component of factor VIII results in von Willebrand's disease, which is a slightly different disease. The gene for hemophilia is recessive and carried by the X chromosome. Because this gene is recessive, disease in female occurs only if both of her X chromosomes carry the defective gene. But this almost never happens because one of her X chromosome has the appropriate gene. Now, if one of her X chromosome is deficient, she acts as a hemophilia carrier, transmitting the disease to half of her male offsprings and transmitting the carrier state to half of her female offspring. In case of males, the presence of defective gene in the only X chromosome results in the disease because the other sex chromosome being Y, there is no normal X chromosome to compensate. The lab tests used for diagnosing the hemophilia A show a normal platelet count, normal bleeding time, but absent or decreased factor VIII. Treatment is by transfusion of factor VIII concentrates or fresh plasma or fresh frozen plasma or fresh blood transfusion. Hemophilia B and C are caused by deficiency of factor 9 and 11 respectively. These are milder diseases as compared to hemophilia A. Next we study thrombocytopenia. In contrast to hemophilia, which is a disease due to defect in the clotting mechanism, thrombocytopenia is a disease due to platelet abnormalities. Thrombocytopenia means the presence of very low number of platelets in the circulating blood. In individuals with thrombocytopenia, the bleeding is from many small venules or capillaries rather than from larger blood vessels, as in hemophilia. As a result, small punctate, meaning pinpoint, hemorrhages or bleeding points occur throughout the body tissues. The skin of such a person displays many small purplish blotches, giving the disease the name thrombocytopenic purpura. In thrombocytopenia, bleeding will not occur until the number of platelets in the blood falls below 50,000 per microliter, and the levels as low as 10,000 per microliter are lethal. Most people with thrombocytopenia have the disease known as idiopathic thrombocytopenia, which means thrombocytopenia of unknown cause. In these people, it has been discovered that for unknown reasons, specific antibodies are formed and react against the platelets to destroy them. Relief from bleeding for 1 to 2 days can often be seen in these patients by giving fresh whole blood transfusions that contain large number of platelets. Splenectomy is often helpful, leading sometimes to complete cure. Next, we study the other major group of hemostasis disorders, the thromboembolic conditions. Thromboembolic conditions are the disorders in which abnormal or excessive clot formation occurs within blood vessels, compromising blood flow to vital organs. Now, an abnormal clot that develops in a blood vessel is called a thrombus. And if it breaks away from its site of attachment and it starts freely flowing, then this freely flowing clot is known as embolus. Several factors acting either independently or simultaneously can cause thromboembolism. Number 1, roughened blood vessel surfaces associated with atherosclerosis can lead to thrombus formation. Number 2, imbalances in the anti-clotting systems can trigger clot formation. Number 3, slow-moving blood has more tendency to clot because small quantities of fibrin accumulate in the stagnant blood. And lastly, widespread clotting can also be triggered by the release of tissue factor into the blood from large amounts of traumatized tissue. Now, this is all for today's lecture. We will continue with the thromboembolic conditions in the next lecture.